Welcome, everybody, to Caraconference 2022, the impact of community-led approaches. I'm Adam Riley, Prevention Manager with Caracol. And before we get started today, I'm going to go through a few housekeeping items. So first, Caracol is Greater Cincinnati's HIV service organization devoted to positively changing lives in the fight against HIV through prevention, housing, and care. For more information, visit caracol.org. And to participate in today's webinar, if you have any technical questions or issues, or you want to introduce yourself, share information, please use the chat function for that. But if you have questions for our panelists or our presenters, please use the Q&A function. And that is what that should look like on your screen if you are doing if you're joining from a laptop or a desktop. And if you're joining from a mobile device, you can access the chat function by clicking the 3 dots more button at the bottom right of your screen, or the Q&A button at the top right of your screen. And thank you to our sponsors. Presenting partner is the Midwest AIDS Training and Education Center at the University of Cincinnati and AETC, AIDS Education and Training Center, with sponsorship from Gilead. We are offering educational credits for today's session. The link to the evaluation will be placed in the chat multiple times through the session, and a QR code is available in the PDF program that was emailed to you on Friday. Each QR code will take you to that respective day's evaluation. You must attend for at least 60 minutes and complete the evaluation by 5 p.m. today to receive education credits. If you're requesting CMEs, contact Mary Beth Donica at the email listed there. That email is also provided in the PDF program and will be in the chat later in the program today. Disclaimer, this program is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services as part of an award totaling $4,198,345 with 0% financed with non-governmental sources. The contents are those of the author and do not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the US government. And these are some AETC resources for continuing education around HIV and hepatitis C. The links to these curricula will be sent in the chat for easy access as well. And now to the disclosure piece for CMEs. Our planning committee members have no disclosures to make, nor does Dr. Moira McNulty. Jessica Schmidt, who is presenting today, does receive a focus grant from Gilead. And this next slide is just some additional disclaimer statements around the disclosure process for CMEs. And with that, we are on to today's program, Rapid Linkage and Initiation of Antiretroviral Therapy, presented by Dr. Moira McNulty and Jessica Schmidt, LCSW. Dr. Moira McNulty is an assistant professor at the University of Chicago Department of Internal Medicine, Section of Infectious Disease and Global Health. And Jessica Schmidt, LCSW, is the University of Chicago's Director of HIV Clinical Engagement. And with that, I'm going to pass things over to them. Welcome, Dr. McNulty and Jessica.
Great. Thank you so much, Adam. Just to confirm, you can hear me okay. Is that right? Great. Thank you, Jess. So today we're going to talk about rapid linkage and initiation of antiretroviral therapy, our experience within a routine HIV testing and linkage to care program in Chicago. Next slide, please. Thank you. So as mentioned, I'm Moira McNulty. I'm an assistant professor of medicine and the director of HIV testing in the section of infectious diseases and global health and the Chicago Center for HIV Elimination at the University of Chicago. And I'm going to let Jess introduce herself.
Thanks, Moira. And I'm Jess Schmidt, she, her. I'm a licensed clinical social worker and our director of HIV clinical engagement with section of infectious diseases and global health, and also at the Chicago Center for HIV Elimination. And as mentioned, I do have Gilead focus funding that we'd like to disclose, and Dr. McNulty has no disclosures. Today, we're going to really provide an overview of rapid initiation of antiretroviral therapy, or ART, including benefits and components. We're going to describe the expanded HIV testing and linkage to care program for routine HIV screening in healthcare settings that we do here in Chicago. We'll discuss strategies for implementation and adaptation of rapid linkage to care and initiation of ART across diverse healthcare settings. And we'll identify some of the challenges and facilitators of rapid linkage to care and initiation of ART. To get things started, we kind of want to know who we have in the audience. So hopefully we can tailor some of the conversation to you all. So we're going to set up our first poll. If you can click, what type of facility do you work in? So a federally qualified health center, hospital, nonprofit agency, or community space, or a substance use or behavioral health treatment facility. We're getting a lot of others. Awesome. So it looks like over almost half of you work at a nonprofit agency or other space. Not too many of you are coming from federally qualified health centers or hospitals. So we're going to really bring in a lot of that hospital and federally qualified health center experience. But hopefully we can kind of also add some context for you all in your spaces. So the second poll we have here is, does your organization currently offer rapid initiation of ART? Yes or no? All right, so it looks like almost 80% of folks do not have any ART, rapid initiation of ART. Some of you do. Hopefully you can provide a little bit of context to what your experience has been like at your facilities, but glad to know kind of some of that background. And then our final poll is, what aspect of rapid initiation in ART are you most interested in learning about? Are you interested in learning about insurance navigation, medical risks and benefits, staffing requirement, best practices, or kind of something else? And that third poll should be coming up in 1 second. Adam, are we able to put up the third poll? I know sometimes running these polls can be a little challenging to multitask across the screens. Or if I can do it. Oh, maybe I can do it. Does everyone see that? Okay. Excellent. Sorry about that. Awesome. So it looks like overall, most of you are interested in best practices, which is great. You know, we're definitely going to try to approach some of the top level information about what are some of the things that were needed. We'll definitely touch on some of the benefits from ART and a little bit about insurance navigation. Not too much, but we will kind of bring it up as in context of the work that we do, because we know it matters. And I'm going to turn over to Maura to kind of get us started.
Great. Thank you so much, Jess. Okay, so we know that early antiretroviral therapy, or ART, leads to better patient and public health outcomes. So for people living with HIV, ART dramatically reduces HIV-related morbidity and mortality, while it also improves immunologic recovery and reduces the HIV reservoir. Early ART also reduces treatment delays for individuals living with HIV. There's also a public health benefit. So viral suppression helps to prevent HIV transmission and an overall reduced community viral load. So more people on ART and treated can reduce community viral load, which is associated with fewer transmission events. And this is all really in support of our U equals U, or undetectable equals untransmittable, and also really a key component of reaching our HIV elimination goals. So whether that's at a kind of city level, a state level, or national ending the HIV epidemic level. And so now really the guidelines, and have for a while, recommend treatment for all patients, with the possible exception of elite controllers, and that's really a discussion with the patient and their physician or other provider. Next slide, please. So what is rapid, oh, sorry, back one, I apologize. So what is rapid initiation of antiretroviral therapy? So newer evidence suggests that faster time to linkage and starting medication can have some really positive outcomes. So what does faster mean? Well, it's really considered to be same day, and it depends on where you look. So it's same day, some places say as soon as possible after diagnosis, within 72 hours of diagnosis, and then some other reports say within 7 days of diagnosis. And it's really essential to have immediate linkage to care for any person who's diagnosed with HIV, since we know that, again, now the newer evidence suggests that there's faster viral suppression, including potentially durable viral suppression, better retention and care, trends toward less mortality, and we would expect less transmission to others as well with that. And so there are now rapid initiation protocols at many institutions. Some, entire jurisdictions follow specific rapid initiation protocols. And before we go further, we'll talk a little bit about some of the specific evidence for rapid initiation and what that entails. So in the US, there have been no randomized controlled trials for rapid initiation, but there have been several prospective observational studies. One of the first was in San Francisco, which with the RAPID initiative, or Rapid ART Program Initiative for HIV diagnosis. And they found that there was a reduction in time to linkage, time to starting ART, and also time to viral suppression, and that there were high rates of viral suppression at 1 year. They also did a pilot in New Orleans where they found decrease in time to viral suppression and improved retention and care for the Rapid Start group. And then also in Atlanta, where they found decrease in time to viral suppression. There have been randomized trials in South Africa, Haiti, and Lesotho. But again, in the US, this is some of our, our key information that we have for how it may operate in our system. So with the RAPID protocol being a success in San Francisco, they actually rolled out a citywide initiative for Rapid Start. And this is an image of that process that they have. So they have a lot of components to it, including specific HIV testing sites. Then they have navigators that then link to these rapid ART hubs within their city to get patients started. Next. Oh, perfect. Thank you. So traditionally, for a new diagnosis of HIV, it would take up to 30 days per the National HIV/AIDS Strategy Guidelines, or NHAS guidelines, to link a patient into care with an HIV specialist, who would then often send labs and wait up to 2 weeks for those results to come back before often having the patient coming back in and then starting ART. In the meantime, you might lose touch with the patient. They may not come back to get their medications. They may not pick up their medications, or they may not prioritize their HIV treatment given that delay. When we use the rapid initiation of ART model, we're essentially trying to compress the continuum of care, making all these steps up to viral suppression happen more quickly. And with that, many of the pilot studies have also shown that there's been improved care continuum outcomes with improvement in rates of linkage and rates of retention. Next slide, please. So with that, there have been national and international guidelines in place recommending rapid initiation of ART. So the Department of Health and Human Services recommends initiating ART immediately or as soon as possible after HIV diagnosis. The IAS USA has similar recommendation as soon as possible after HIV diagnosis if patient's ready to commit to treatment, and then also recommends removing structural barriers that may prevent patients from getting into treatment. And then the WHO also has recommendations that rapid initiation should be offered to all people living with HIV following a confirmed diagnosis and clinical assessment, which is same day or within 7 days. Next slide, please. Thank you. So while these guidelines are in place and we know that the evidence, nationally and internationally exists to support it, it really hasn't been implemented very regularly across all health systems in the US. This is in part because in practice, rapid initiation of ART can be really resource intensive and may require an overhaul of existing systems for linkage to care and initial management of diagnosis. So it would frequently take systems level and individual level provider behavior change to really enact rapid initiation successfully within a system, whether that's an individual clinic or a larger healthcare system. And as such, it can be really difficult to initiate and or sustain in many care settings. So you can see here, this is from the New York State Department of Health AIDS Institute and their guidelines for rapid initiation. And there are a lot of steps and a lot of different people who need to coordinate their time to see a patient, on that day that that the rapid initiation would occur, often taking a 2 to 3 hour visit to get all the components completed. Next slide, please. On the left, a paper by Coffey et al. Described the process components needed for rapid ART. So these include things like a tight working relationship between testing sites and rapid ART sites, warm handoffs and accessible linkage coordinators, early and sustained access to ART, expedited insurance and payer source coverage and clinic enrollments, same-day clinician visits, medical education availability, and then close follow-up, patient navigation, ongoing HIV education, and coordination with retention teams. On the right side, this was a qualitative study with providers and staff in San Francisco and then also in Chicago at the Howard Brown Health Clinic on what made their Rapid Start program successful. And they noted that a presence of an implementation champion was really important, comfort and competence prescribing rapid ART by the providers, expedited access to medications, expertise in benefits, linkage to care, and care navigation, and then flexibility and the organization's ability to adapt, as well as taking a patient-centered approach and really strong communication methods and culture. Next slide, please. Great, thank you. So with knowing these components that have been described, we assessed the real world implementation in a routine HIV screening program in Chicago. This program has a range of diverse healthcare systems and healthcare organizations as a component, and our rapid initiation process primarily used existing resources within this program. And the program is funded through the Chicago Department of Public Health. And so there were some resources available for the testing and linkage to care as a component of the program. And with that, I'm going to turn it over to Jess to talk a little bit more about the program and what those components are.
Thanks, Maura. Next slide. Oh, sorry. So yeah, we're just now that we've kind of talked about general approaches to rapid linkage and initiation of ART, we kind of want to shift gears and talk about what is the initiative that Dr. McNulty and I work in, and a little bit about some of the, the experiences that we've had over the last 10 years. So as Dr. McNulty mentioned, the University of Chicago is a lead organization in a grant that's funded by the Chicago Department of Public Health. And we've been funded since 2011, actually, and now funded under the HIV screening and healthcare settings in their healthcare access portfolio. As a lead organization, we support the data management, technical assistance, and implementation processes at our partner sites. We have 13 organizations that we work with, a mix of safety net hospitals, academic centers, federally qualified health centers, and really target efforts at those sites to implement routine opt-out screening in accordance with CDC guidelines. That means, at different sites, it's primary care settings, emergency rooms, inpatient settings, or community-based testing on occasion. We go back to the previous slide still. So we do work to follow the National HIV/AIDS strategy of linkage to care within 30 days. And we know that this is a UDS measure that many of our FQHCs recognize as well. And Dr. McNulty will review some of the data, but we really try to get folks to do more rapid linkage to care than the 30 days, but we know that's kind of our end goal. And the XTLC ultimately is a community of practice to improve the rates of HIV screening and linkage to care. And we work with our partners to share best practices, what worked, what challenges have we faced, and kind of talk about opportunities to disseminate information more widely. And the continuity of this project over 10 years actually has been pretty central to our success, which is, great to have some of these partners. Not everyone's been with us since 2011. We've had 3 or 4 sites join us since 2016. But you can kind of see here on the map, this is a Chicago Department of Public Health map of incidence rates of HIV in 2019. And in the red and the dark blue, those are obviously the areas of higher incidence rates. And that's where most of our partner sites are located. And that's why the grant was initially funded in 2011 to target the south and west sides of Chicago and really put resources there where there haven't been resources before. We've seen increasing numbers of healthcare clinics pop up, especially on the south side. But at the time there was very resource limited spaces. We also in 2019 were able to expand our service area beyond the Chicago area limits into suburban Cook County. So we were able to add 2 hospitals, one in Maywood, Illinois, which is right outside of the city, and one in Harvey, so Loyola and Ingalls. So here you can kind of see our list of hospital partners and FQHC partners. So we have 7 hospitals and 6 FQHCs. As I mentioned a little bit earlier, the longitudinal aspect of this, we are so grateful to have many of these partners for many years, and it has allowed us to kind of have the continued ability to process, approve, and see organizations through many changes, which it could include staffing turnovers, update to state policies or national guidelines, shifts and modernizations in our electronic medical records, and kind of just any internal clinical structures that folks have changed over the years. So how do we kind of do this troubleshooting and implementation? We have annual site visits, all site visits. So all of our partners have 1 or 2 representatives, anyone they want to attend, come out twice a year. Now we do it all over Zoom, but we kind of keep sites up to date about what initiatives in HIV prevention and screening are happening. So often that includes best practices in HIV screening protocols, but we also talk about changes in HIV treatment, PrEP initiation, hepatitis C screening, or anything kind of in the realm of HIV prevention to make sure that folks have a shared learning space where they can kind of ask questions and seek input from us as a lead organization or their colleagues and peers. And so as a group, we can really discuss any impact any national policy will have and how to adapt these new recommendations into our healthcare systems in a more rapid way. One example of this was in the state of Illinois in 2016. The Illinois AIDS Confidentiality Act was updated, and we were able to change our routine screening from opt-in to opt-out. And, in theory, that's great. We're all excited. We don't have to do these written consents anymore. However, many sites had to figure out how to kind of encourage their healthcare providers and institutions to adapt the new policy recommendations and mobilize staff education, update legal protocols, have legal on board and update policies and protocols in order to be able to actually implement those changes. We also hold individual site visits annually with partners to review their testing numbers and linkage to care rates and troubleshoot any issues they may be facing. We offer staff training, so we'll go into these organizations and kind of provide technical assistance and on any topics that their staff might be interested in. We provide data solutions if reporting and collecting the data is a barrier. but we really prioritize that because that's how we monitor people's outcomes and make sure that they're getting quick and timely linkage to care. And we also provide these quality assurance reports quarterly to make sure that there's no issues that kind of need to be addressed and process improvement that needs to be implemented. And in these site visits and all site, our partners really have like an opportunity to hear from each other, which I think is really great because they can kind of translate those experiences to their own site. And we know that there's not like a one shoe fits all method for routine screening. And it can look very different at a community health clinic where there's no HIV specialist on site compared to an inpatient setting or the emergency department. So kind of hearing those different approaches and seeing real-time examples of screening and linkage to care can allow sites to kind of pick and choose what applies to them. And then also kind of bring those ideas back to their respective leadership teams and say, hey, they're doing this over here. Can we try that out? Next slide. Here's just kind of an overview reflecting on our experience over the past 10 years. So you can kind of see in 2011, we had just 3 sites and we're doing 11,855 tests. And now in 2020, we had 13 sites and 112,713 tests, which, actually was pretty good. We only saw a slight reduction during the COVID-19 pandemic. And Dr. McNulty will talk about a little bit some of the adjustments we made at our institution. But over that time, the program has identified over 1,200 individuals newly diagnosed with HIV. And in 2020, we identified 169 individuals newly diagnosed with HIV. And although it's not listed here, we did rebound in 2021 and tested over 130,000 individuals as well. And we continue to kind of process improve. You can see that we've seen increases since 2015 when we still had 12 partners. We've continued to grow and expand these programs. Next slide. And so just to kind of reflect back, Dr. McNulty shared this graph, we're really looking at the routine opt-out HIV screening being integrated into routine healthcare, which could be a primary care visit, when someone's hospitalized or during an acute emergency department visit. And we want to really think about how can we compress the continuum of care and shorten the amount of time it takes to get someone linked. Next slide. So as Dr. McNulty mentioned earlier, there is some evidence that testing in healthcare settings results in faster linkage to care as compared to community testing. So a lot of you on here mentioned that you're from community settings. So you're like, yeah, tell me about it. Like I have the struggles where I don't have a healthcare provider on site. I'm doing testing and I'm trying to rapidly link them to care, and it's a little bit more difficult. So that's why our program, we're fortunate that we are based in a healthcare setting. So why does the routine screening matter? Why is it important? Well, we know that we want to normalize and destigmatize the testing of HIV and really prioritize it as an entry point into the continuum of care. So we know there are benefits for faster linkage to care and initiation of ART, which Dr. McNulty mentioned. And it's been proven again with a review of the reduction of the NHAS linkage to care guidelines from 90 to 30 days. It's been demonstrated that individuals who are linked to care within 1 month had significantly higher rates of viral suppression than those linked at 2 or 3 months, and a much quicker reduction in viral load as well. Next slide. So knowing the benefits is great, but how do we then, going back to our program, really demonstrate this and implement this in a real world setting? So we wanted to think with our partners, how do we shorten the time for linkage to care for us, depending on what our strategy is. So there's a variety of different approaches. And many sites have a team or individual who is responsible for reviewing all HIV positive results and determining next steps. And like I said, everyone kind of does their own referral pathway based on staffing models at their site of care. But we know like some sites use licensed clinical social workers, medical providers, peer navigators, linkage to care specialists, and community health workers. So for example, at the University of Chicago, our infectious disease team is responsible for the notification and linkage to our emergency department, but we also monitor results across the hospital. So all results come to Dr. McNulty and our team of social workers from a daily lab report. And once the results are confirmed, we contact patients with new diagnosis of HIV, discuss the results, provide psychosocial support and health education, and schedule a follow-up. We really try to get that follow-up as an overbook in our clinic if necessary, but also like same day or next day if possible, and if the patient's ready and able to come in. Another FQHC, however, the primary care provider who might be doing the test is the one who notifies the patient of the result, and then has a community health worker or linkage to care specialist support and navigate that person through the continuum of care. And in those instances, the partnerships also are really helpful, because if you don't have an HIV provider on site, you hopefully can link with a program affiliated site when possible. Or we can kind of like leverage those existing partnerships to find, Ryan White clinics or other HIV care providers that our patients can be quickly scheduled into and provided ART. And what matters most is that the patients are linked to medical care with an experienced provider and supports and resources that we'll kind of get into a little bit in the next slide. But we also want to make sure that that's centralized so that the healthcare system knows how to respond when we have positive results and can provide the best and quickest support. Yes, the next slide. So what are some of the important resources that we need for quick linkage to care and initiation of ART? One of the most important pieces that we often find is our interdisciplinary team. And again, many of the sites or community health spaces or even offering services in the community don't have this interdisciplinary team. So we're very fortunate, but I do think it's also critical to be able to rapidly identify the resources that patients need and get them connected to care. So for us, that means our medical team, our pharmacy team, and our social work have to work really closely hand in hand to get the patient everything they need from day one and reduce barriers to care for engaging. So this support includes facilitating, access to ART regardless of an insurance and individual's insurance status and the medication that the provider is choosing to initiate them on. And so we really, our team works together to remove the immense financial burdens of HIV medications, whether that's via industry supports and applications for ART or AIDS drug assistance program, in Illinois that we have. We want to make sure that people go home with medications in hand when they're ready to start. Dr. McNulty kind of alluded, we don't want someone to have to wait until results of a genotype come back. We know it's pretty safe to be initiating those medications. And then if there's any adjustments that need to happen, they can do that later. But we want someone to feel like they're moving forward and, having access to that drug is a really important piece of that. And we don't want them to have to worry about paying for this medication that they're going to have to take for the rest of their life. So the other thing to note with that, however, although our ultimate goal is to link someone to care and initiate our ART, we really do need to have a person-centered approach and understanding that person's priorities. So we really need to make sure that health education and supports are tailored on some level to that individual's needs and concerns, and create that environment of support and transparency. So that's why we also list on here kind of some other resources and retention supports, so that we want to reduce barriers to care for individuals. So for us, that looks like providing transportation to visits, providing food or grocery gift cards, Walmart, Jewel, Target, and assisting with FMLA or ADAP applications. We also want to know what other health concerns this person who comes through might have, and that includes things like gender affirming care, case management, housing, employment supports, behavioral health, and anything else, to be honest. And one other thing to note, is that it's not always A to Z. We know that folks have a lot going on, phone numbers change. So we also really rely on an outreach and engagement team to follow up with individuals who don't make it to their appointments, and that can include phone calls, letters home, and even house visits. Next slide. So also just want to briefly mention that, while a lot of our conversation is focusing on new diagnosis, we also want to be thinking about this for folks who have been living with HIV, and kind of holding ourselves accountable to those folks as well, and holding a similar standard for rapid linkage to care and reinitiation of ART. Although we know it can be more difficult, we also know there's a great opportunity window. So there's a lot of reasons that individuals might not be currently engaged in care. This could be due to insurance navigation, lack of urgency from previous providers. And, that's actually why we try to make sure that patients, for example, if they're hospitalized and haven't been in care, we want to make sure that they get discharged with medications when they leave. Folks may be experiencing housing instability, substance use, or mental health concerns. They may have had negative experiences or discrimination in the healthcare system previously. They might have been prioritizing other concerns. They might be caretakers seeking employment. Or we also need to recognize that occasionally folks do not desire to take medication or feel that other holistic approaches are preferable. And again, although it may not be our medical advice or, personal advice, we want to recognize individuals' autonomy, but hopefully keep and practice a harm reduction strategy to kind of hopefully eventually get someone at least in medical care, and the goal of getting back on ART. We also know, like I mentioned, that it's an opportunity window. So folks are coming, if they get tested, they're visiting for a particular reason. They may not have heard all of the options available to them. And we know that it's important, from a public health standpoint, to get folks virally suppressed. And we want to leverage that as, treatment is prevention. Although many of us know that U equals U, undetectable equals untransmittable. I don't know that message has been completely shared with all of our clients. And we want to share that hope with our clients and encourage them to engage in treatment potentially. Next slide. And just to kind of show you what our linkage to care has looked like over in 2020, we've been able to link 85% of our newly diagnosed individuals to care. So that's of the 169. And most of those the median time for linkage to care was 8 days. And so for folks who had previously been diagnosed with HIV, we identified nearly 500 individuals. Only about 119 of those folks were actually eligible for linkage to care. And of those, we were able to link 65.5% back into care with a median time of 17 days to visit. That makes sense, kind of what we know about and discussed about re-engagement. But we did prioritize those folks with visits as quickly as we were able to as well. And for those newly diagnosed with HIV, we saw a median viral load of 78,900 copies and a median CD4 of 291. And that just kind of give a little bit of context, but Dr. McNulty is going to discuss a little bit further what we actually saw with our rapid ART initiative.
Great, thank you, Jess. And I did just want to respond to one item in the Q&A about the possibility of utilizing Cabenuva in rapid ART. And so, the oral lead-in for Cabenuva is actually optional now. So you don't have to do the oral lead-in, but we still have the FDA recommendation that, it's only approved for people who are already virally suppressed. To start Cabenuva when someone's virally suppressed. And so that's somewhat limiting for using it for rapid initiation of ART. However, there was one study that just came out from San Francisco, and it was Christopoulos, and it's in Clinical Infectious Diseases, where they did look at outcomes for starting people who are not virally suppressed on Cabenuva. And they were quite good. And so I think, though, to really use it for rapid start, we would need a little bit more, probably more studies and more information on the safety of doing that and the likelihood of not developing resistance and things like that. And also just making sure we have models of, because in the San Francisco model, these were people that were already retained in their clinic. And so just making sure that we have models that would ensure that those people who are potentially doing rapid start with Cabenuva sometime in the future, if it seems like that would be safe to do, yeah, so just making sure we have models that support retention for those folks. So, okay, so we're going to go back to our program for a minute. So, in our evaluation of our rapid initiation efforts. So we looked at and evaluated our rapid initiation process within our routine HIV testing program here in Chicago. We chose to initially look at acute HIV infection as a starting point for assessing our rapid initiation processes within the XTLC program, since it was a subset of patients and also really a subset of sites that we could look at. And also just knowing that acute HIV infection patients have a very high viral load, potential for transmission to others, and patients may be symptomatic and really overall high priority for early therapy. And so we wanted to, again, look at this initially to see how we were doing with rapid initiation within our partners within the XTLC program. In addition, this really allowed us to kind of work through some of the processes that our partners were using, and use this as a way that we could identify some of the weaknesses and some of the best practices, to be able to take that to things like our all-site meetings and our community of practice with the other partners to understand what works best and what across our different settings. Next slide, please. So 6 sites over the time period that we looked at identified acute HIV infections. And this was from 2016 to 2017 when we did the initial evaluation. For each site, we determined their protocol for linkage and initiation of ART. And each site really, this was very real world. So each site independently decided whether or not they were going to, do rapid initiation and develop a specific procedure or protocol for it. Or continued with their existing procedures for linkage to care, which at the time was primarily, within 30 days based on those NHAS guidelines. There was no universal protocol. And so again, this was really reflective of real world conditions. We did find across the sites that there were differences in things like lab reporting. So how often were the HIV results being reviewed by someone in the testing program to identify who was diagnosed and who needed linkage. There were differences in how they were linking to care. So who was doing it? So was it in-person navigation? Was it over the phone? Some other version of navigation and connecting with patients. And then also really different across, I guess really just one site was able to get point of care results, and the other sites were primarily like a lab-based test that would come back at some point later, either later in the day or another day. And also different processes specifically for acute infections. And so a couple of the sites did not have really specific, so sites A and C did not have specific processes for acute infections, while most of the other sites did. They prioritized the rapid start for those patients. Next slide, please. Okay, so I mentioned 6 sites identified the acute HIV infections. 5 of these sites were more hospital-based systems with emergency departments, and 1 was a federally qualified health center. Of the 334 new diagnoses, about 10% had acute HIV infection, so that was 33. And the median time to linkage overall was 11 days, with 15 days to initiation of antiretroviral therapy. There was a really large amount of variation between sites in these outcomes. And for instance, site C did not have a specific protocol, and you can see that, their time to linkage was almost 40 days, and same with site A, they did not have a specific protocol in place, and their time to linkage in this was 1 patient, but it was, 27 days. So that was, some of what came out of this evaluation was really some of the lessons that we learned and how we could improve across our sites, was that, having a specific protocol really does, in fact, help. Next slide, please. You can also see that for our acute HIV infections, our patients with acute HIV infection, the viral load was much higher, so a median of over 2 million copies, as compared to other new infections where it was around 50,000 copies. And amongst our patients, many had symptoms, so really only one was asymptomatic. Next slide, please. So there were a number of lessons that we learned. Because we have the routine HIV screening and linkage to care program in place, there weren't many additional resources that were needed across sites to incorporate rapid initiation into their existing processes. However, it still required a change at the different sites in terms of how they were operating and the availability of same day or next day appointments and things along those lines to make sure that they could in fact do rapid initiation. However, the integration into some existing HIV screening programs is a really promising strategy for kind of scaling up this intervention without, the requirement for bringing on a whole new team of people potentially to do this. Reviewing data and the programmatic aspects allowed for improvement of rapid ART processes following this publication. So again, we brought this to our partner sites and we're able to look at some of the things, some of the areas that were kind of had an open discussion to some extent after presenting the data. And we're able to identify areas where we could improve upon what we're doing for our patients. Sites did have different barriers to rapid linkage to care, but all of the sites have been working to shorten the timeline and then also not do it just for acute HIV infections, but now also for all new diagnoses and some for the patients who need to, who had existing diagnoses, but need to relink and restart ART. We still have some challenges, of course, across some of our smaller sites that do not have an HIV provider. Next slide, please. We also ran into plenty of challenges during the COVID pandemic, but we continued to work on being able to offer rapid start throughout the COVID pandemic, particularly at the beginning. Next slide, please. So at the University of Chicago, we built out our HIV testing capacity during COVID so that we could test for HIV in areas in the emergency department that were primarily for COVID evaluation. We saw our HIV testing initially drop and then pretty quickly improved at the U of C to pre-pandemic levels. Next slide, please. Because we were able to concurrently test for COVID and HIV, we did see a higher rate of diagnosis of acute HIV infection during the early days of the COVID pandemic. All of those patients were linked and initiated on antiretroviral therapy with a median of 1 day from the time of their viral load returning, but a median of 3 days from the sample collection, primarily due to delays in the reflex confirmatory testing and a result of high demands on our laboratory personnel and some scarcity of supplies during early COVID-19. We also did rapid initiation for all new diagnoses, but again, reported here on the acute HIV infections, given that we were seeing really high rates. Next slide, please. So some of the facilitators of rapid initiation of ART that we have identified through this process and working with our partners. So one is being able to really rapidly and quickly identify true HIV positive results. So our HIV screening test and confirmatory tests with a reflex to viral load has been a really important strategy to be able to quickly identify who's a true positive versus who may have a false positive test result, especially when those results are discordant. We also have automated daily reports of all of the reactive HIV results that are reviewed by an experienced social worker who also does linkage to care and by one of our HIV providers. The linkage to care process has really been facilitated, especially within the health systems that have most of the testing done in the emergency department by having a really close partnership between the emergency department and infectious diseases. Again, this centralized review of results for follow-up has been really crucial so that everyone knows whose job it is to follow up and link the patients to care, and that person who does that linkage to care has access to those same next day or same day slots, knows the process and who to communicate with, having the strong internal communication. Again, those really clear linkage to care processes and protocols, with the same or next day visits available, and then the multidisciplinary team that's available for patient evaluation, including the pharmacy presence at the first visit to ensure that they can get their medication. And then across all of our sites, collaboration with our expanded testing and linkage to care partners. So facilitating our partners learning from each other and their experiences. We review the site data and the patient outcomes so that sites can identify where they may need to make improvements. Sharing some things like electronic medical record report structures and best practice alerts. And then sharing education from the latest recommendations. Next slide, please. There have also been plenty of challenges for rapid initiation of ART. And so these have included things like delays in the confirmatory testing, particularly in places, again, with no reflex testing for the viral load for patients who have discordant results. Availability of appointments, and that has particularly been a challenge for sites where some of the providers may not be as comfortable with HIV care because they're not trained in infectious diseases or in HIV primary care. And so some of the federally qualified health centers, we've had to kind of work on developing, or suggest perhaps developing a champion for rapid ART who is more comfortable and can learn about that process with some, clinical backup if needed. Also, the ability to provide medications to patients. So there are always insurance barriers, and most of our sites do not provide starter packs, which had been shown to help in some of the pilot studies that have been done, or I guess not pilots, but observational studies that have been done. And then finally, also the ability to notify patients of results. So a lot of our testing across sites, if it's done in the emergency department, those patients sometimes can be harder to contact just if we don't have a reliable way of getting in touch with them and they have no real existing connection with our healthcare system. That can certainly be a challenge. Next slide, please. So in conclusion, rapid initiation of ART for HIV can be successful by incorporating it into existing programs for routine testing and linkage to care with minimal existing resources, but it really does require a shift in processes and this multidisciplinary buy-in and really strong communication across the different teams doing testing, linkage, other support and retention services, and providing the clinical care. So there are many barriers to implementation. It's not necessarily easy, but they're not insurmountable. And so incorporating rapid initiation of ART into existing testing programs really could be considered as a strategy to help scale it up and help us achieve our goals of HIV elimination with this, important intervention for our patients. Next slide, please. So we do have some acknowledgements. So we'd like to acknowledge the Chicago Department of Public Health, who has funded the expanded testing and linkage to care program over the years, as well as the Centers for Disease Control and Prevention, all of our XTLC partners, and then our wonderful clients and patients, and then of course some other specific individuals who have really largely contributed to the expanded testing initiative, as well as getting rapid start and rapid ART into place within our organizations. Okay, and I think the next few slides are references, and then I think we can stop there for any questions or comments.
Hello, Dr. McNulty and Jessica. So there aren't currently any newer questions that are in the Q&A, other than the ones that you, of course, have answered in the Q&A. So I just want to send out a reminder to the audience to please submit any questions that you may have in the Q&A function, and we'll allow some space for Dr. McNulty and Jessica to answer that.
Hey everyone, this is Zoe from the Caraconference Planning Committee. I've been here in the background helping out with the technical issues, but I have my own question for Dr. McNulty and Jessica. I am curious about your experience in working across different hospital systems. Here in Cincinnati, there is a pretty strong rivalry and some competition between the different systems. So I'm curious how you all have been able to accomplish that.
I can say we leverage that. You know, we try specifically with like emergency rooms, you know, which is where we actually identify a lot of folks who are newly diagnosed with HIV. You know, we say, hey, we're doing this over at University of Chicago. We're doing this over at University of Illinois, Chicago. So, you know, that actually gives hospitals, you know, whoever the person is that's at that hospital, they are able to go and say, hey, this is happening at another quote competitor. We need to be doing this as well. So, you know, I'll say that component. Obviously, in some aspects of other aspects of care, there might be competition to kind of keep your proprietary information. That hasn't been our experience. People want to share what's worked for me. This is where I've attached it to in the lab order set. This is what, like, literally screenshot. So we also kind of like rely on each other to kind of show what's worked. And I think that that's been the attitude and approach for everyone. I don't know, Dr. McNulty, if there's anything else you would add.
Yeah, no, I think, you know, in part the expanded testing and linkage to care collaboration that we've had with our partner sites. Right. We've been able to leverage that idea of kind of competition and providing some benchmarks to say, hey, these are how our sites are doing. This is, you know, where you should be. But also, I think we really do have a shared agenda. And so I don't think there's been a lot of competition in the sense that, oh, we want our health system to do better than others. I think we're really all very focused on trying to do the best for the patients, and for overall, you know, public health in our, you know, what we can impact in our area. And so I do think that the members of the partnership have been really highly focused on that, and not quite as much with, you know, trying to keep information proprietary or anything like that. Although I'm sure some of that happens.
And there's 2 more questions in the chat box, I guess we could just answer. So Jacob asked, how soon are you able to get a person on ART after diagnosing them in the emergency department? So our 2020 numbers that we shared, I think the median day was 8 days from the day they came in to diagnosis. So just one comment on that though is we don't actually get results in real time. So, you know, we have a day delay to get the viral load uploaded. So it's actually probably, you know, once we have the viral load, it's probably 3 days, but the median time was 8 days from our ED. And then the second question sorry. Dr.
Oh, I was just going to say too. Yeah. So if you look at from, you know, if you look at it from the date of diagnosis, not the date that they were in the ED and got the test done, but the date that the result came back, it is a shorter period that we're able to get them in. But I think even with that, I think it's still closer to 5 days.
And the second question from Julie Patterson, were you surprised to see a decline in your positivity rate over time? Did you find that your funder was okay with the decline? Dr. McNulty, would you like to answer that one?
Sure. Yeah. So I think in part we are doing a lot more tests. And so, you know, you're going to see a decline in, you know, a potential decline in positivity as you're doing more tests. But I think also over time, and we didn't present this data here, but over time we have found that, especially as we bring a new partner on, we initially get a lot of, or many new positives. We see many more new positives for a few years, and then it does start to decline. And we actually see that, and we talk to our funders about it, as potentially a good sign that we're capturing, the population who needs the testing. We also have, we do test a fair number of people who have been previously diagnosed. And so some of those people are in care, but many of them are not. And it is an opportunity. And I think our funders see that there's, an important opportunity in that to get people relinked to care and re-engaged. Okay, so we also have a question. What ways can we address the ED providers' discomfort with HIV testing and access? Okay, so I'll start, and then maybe Jess, you could jump in. So we've done a few things around that. One really big thing, or a couple big things, I guess. One was taking the test results review and notification and linkage process out of the ED hands. So once the ED sends the test, they have no more responsibility for that test, the reviewing the results, nothing. It falls on our infectious diseases and our linkage to care team, who we get a daily report of all of the reactive test results, and then we do the linkage to care. So I think that has been made a really huge impact on making the ED more comfortable with testing. Other things that have really helped, and I can't emphasize this one enough, is we have an ED champion. So Dr. Kim Stanford, who's in our acknowledgements, at least, and most of our sites that have an ED have someone in the ED who works as their champion for testing. And she provides regular education. She updates all the providers, all the nurses on how they're doing with testing for their patients. And, she tells them what the outcomes are for when patients are diagnosed and what happens. And that, we got these people linked, and, kind of makes it a team effort. She holds contests for, testing, and gives out little prizes, all sorts of stuff to help it remain a priority in the ED, because there are so many competing priorities. And then finally, we've really put into place a series of more automated testing that starts in triage in the ED through the nursing staff. And so it's less of an issue with the providers having to remember to order it, because it happens kind of as an automatic pop-up. And I will say too that the other thing that really can't be emphasized enough is the impact of changing the Illinois policy on doing opt-out testing. So that really allowed us to remove the need for a second consent for a patient that was specific to HIV testing, and really improved our testing rates quite a bit. Okay, I'll pause. Jess, do you have anything?
Yeah, no, you really hit most of it. The only thing I would add, we did also really try to enforce that we're minimizing this in people's workflow. So we don't want to add work to, emergency departments' efforts. We want to make sure that everything is streamlined and clear so that it's automatically ordered. They don't have to think about it. And we also attended multiple emergency department faculty meetings and staff meetings to kind of just answer every single question someone might have, show our faces, show who's making the phone calls, and really leveraging our ED champion as well to kind of be that other person to kind of really just address any concerns. Even if we thought the concern was kind of silly, as someone who does the work, we didn't act like that. Everything was important. We want to make sure that all of their concerns get addressed and that it's taken into consideration, because if we don't, it's not going to be successful. So really hearing out every little bitty concern.
All right, that appears to be all of the questions in the Q&A. I'll just give one more moment just in case there are any last minute questions. Otherwise, I want to say on behalf of Caracol, we really appreciate you, Dr. McAnulty and Jessica, for doing this presentation today. Thank you so much. And just a reminder to everybody in the audience to please complete the survey for the CEUs and the CMEs by 5 p.m. today. And if you're also, if you're seeking the CMAs, please do the survey and reach out to Mary Beth Donica via email. And then I also want to say another reminder that we have our third session of the week. So please come back tomorrow if you're interested. It'll go into HIV cluster response in a local county here in the greater Cincinnati area. Otherwise, thank you all for attending. I greatly appreciate it, as does Caracol, and I hope you all have a wonderful rest of your afternoon. Thank you.